Thank you. Okay, so like one last virus is the infamous virus, Zika virus. Again, it's an earthborne virus. It belongs to the Flaviviridae family as dengue fever or dengue virus. Transmission, it's Aedes mosquitoes, Aedes aegypti mosquitoes are the same as with dengue virus. It can be transmitted sexually, maternal, intrauterine, or perinatal, other blood transfusion, laboratory exposure, organ tissue transplantation. Reservoir is not known yet. So you had several outbreaks. It's been around for years. However, recently, 52 countries are involved in outbreaks with Zika virus. It started in 2007 in Yap Island, 2003, French Polynesia, 2015, the Americas, specifically Brazil and Colombia, Africa, Cape Verde. Incubation periods, few days for Zika virus, signs and symptoms, fever, skin rashes, conjunctivitis, muscle and joint pain, malaise, and headaches. These symptoms are usually mild and last up to 7 days and no noticeable complications. However, when complications do happen, you have neurological, Guillain-Barré syndrome, which was reported in 9 countries, autoimmune conditions, congenital, specifically microcephaly, as in the case of Brazil and French Polynesia. This map actually demonstrates the relationship with microcephaly, Guillain-Barré syndrome status. As you notice that wherever there is an outbreak of Zika virus, you have more or less overlapping of Guillain-Barré syndrome and microcephaly with Zika virus. This is another regions where other countries are affected. As I said, a total of 52 countries are infected at the moment. So how do you diagnose Zika virus? It's pretty straightforward, PCR, serology. However, with serology, you have to keep in mind the risk of cross-protection with other viruses, especially in those regions where you have the Americas or Africa or Southeast Asia, where chikungunya, dengue, yellow fever is abundant. PCR is your gold standard. However, you need to get it within the first 7 days of onset of symptoms. Treatment, it is self-limited, and you treat the symptoms as you go. Prevention, no vaccine available. However, it can be prevented with mosquito exposure reduction, either from the source or the contact. Thank you.
Thank you so much, Dr. Haya.
Presentation. I would like, during the breakthrough of H1N1 in Kuwait, or we noticed that the doctors will give Tamiflu, okay, during the symptoms appear, or even after a while for the patient.
Yes.
And do you think they have to give or after the symptoms will appear, or they have to give it for the member of the family as prophylactic?
Okay, so that's a major question.
Thank you.
Basically, with Tamiflu or oseltamivir, its efficacy of that specific drug is in the first 24 hours of symptoms. So the sooner you take it, the better the efficacy of that drug. So there is no point of taking it at day 4 or 5. You're just exposing yourself to the side effects of the drug without the benefits of that drug. And you have to look at your patient, whether it's a healthy adult, no chronic conditions, then you might not even need to treat that patient. You have to look at the case in front of you. However, with those with chronic conditions such as pregnant ladies, diabetes, hypertension, elderly above 60, children below 2 years, you have to treat them as risk factor individuals and either treat them as soon as possible, or you have to give them certain prophylaxis during the outbreak in their house or household. So it has to be, in a way, it has to be organized. You just don't give oseltamivir to everyone at any time.
Dr. Haya, just a question again. Now, we have to diagnose before giving Tamiflu, right?
Yes.
And it takes time to give
because with especially in winter months, you have lots of viruses that and the symptoms can overlap. So there is no point unless it's the weekend. You know that the result will be late, and you have a high suspicion that that patient might have influenza A virus, or he has major risk factors. You do not need or you don't want to take that risk. So go ahead and start your oseltamivir as soon as possible. Once you have the result, you can stop the treatment. But usually in peak seasons, the results should be available within, can be within 24 hours, within 48 hours.
Any more questions? Yeah, the lecture for Dr. Nawal, she actually apologized, she's unwell, so it's cancelled. Thank you for attending today for our pediatric session, and we hope you a nice evening. Thank you so much.
Study basically about 50 patients. Before I go into the conclusion, I'd like to tell you that out of the four patients who received stem cell treatment as part of phase 1, 3 of them gave up insulin, 1 of them still on insulin as 1 dose. Out of the 3 who gave up insulin, 1 of them went back and started taking insulin. We do not know why. We discussed with Dr. Zaidan last time why this person is going back on insulin. We believe that she received a bad medical advice where the doctor told her you can go ahead and fast Ramadan, and that led to severe dehydration. Ramadan, July, summer, you remember? And she's only 11 years old, so she fasted 19 days. On day 20, she had a DKA, and she came up with some problem. So she was put back on insulin. And then later on, after 3 months, again, she gave up insulin injections. But 6 months after that, she started taking insulin again. We believe that this might have a role, or we don't know what's the reason. We gave her a second injection of second round of immune modulation to see if it can help or not last week, and we're watching on that. As a conclusion, executing clinical trials is a very long process and requires extensive experience. Please understand, as of today, we spent over $14 million as a cost for our clinical trials in Jordan and the US, only for diabetes, infertility, and spinal cord injury. So therefore, funding is not available in our countries for clinical trials. And drug companies will not support you because there's no benefit to drug companies. Treatment of chronic diseases with a Jordanian method is safe. We have treated over 800 people so far with different diseases, different conditions, and we have very, very little, if any, of side effects. Efficacies and success rates depend on many factors, infertility, for example, has different factors. Diabetes has different factors. Spinal cord injury has different factors. We have treated some of the patients were Kuwaitis who suffered from blindness and other studies. All of them are clinically approved methods, but the method for that disease is clinical trial. More research needs to be performed in order to draw more solid conclusions. And we need to do more work. This is our team as of 2015. We have our team who are scattered around the world, and this is our team in Jordan here. And we have more people who are not shown here. They don't want to show their picture. I think they think they don't look as beautiful. So with this, I would like to thank you for your attention. I'll take questions.
Thank you, Dr. Adib.
كيف بالوقت؟
Excellent. No, very good. Excellent.
Okay. Questions or?
No, later.
Okay, later. Thank you.
We'd just like to thank you for your excellent presentation. As a matter of fact, I think we need to give you 2 minutes extra. I'm Dr. Sulaiman Al-Saad. I am a consultant neonatologist and representing also the Kuwait Medical Association and the Kuwait Pediatric League. I have the pleasure to introduce my senior pediatrician, consultant pediatrician, Dr. Nafoudi Shimiri. She is the head of the Department of Pediatrics in Mubarak Hospital, and she is one of those founders in Kuwait and taking care of kids with asthma. Please welcome with me, Dr. Nafoud.
Thank you very much, Dr. Sulaiman. It's my pleasure to be with you here this afternoon after this very heavy lecture by Dr. Zu'bi about the stem cell and diabetes. I was asked actually to talk about an update in pediatric asthma, and it's very tough to bring you here this afternoon on Friday just to talk about asthma, which seems to be very well known to everybody. However, we have few bits and pieces about asthma that are new. How does this thing start, please? Can you start the lecture? Not moving the mouse. Okay. So why are we concerned about asthma? Why are we here discussing asthma? Asthma is one of the most common chronic diseases in childhood, and the prevalence is predicted to be substantially increased over the next 2 decades. In the States, they have around 22 million patients affected with asthma, with 6.8 of them are in the pediatric age. It imposes a significant burden on the healthcare system, and it seems nowadays that everybody is very concerned about money and the budget and where to spend it. Asthma costs are directly related to the patient's level of asthma control. Predicting those patients who are at high risk of having very bad asthma, who need hospitalization and will take a lot of money from the budget, is very important. Poorly controlled asthma is very expensive, so we have to work and improve the control of patients with asthma. Investment actually in prevention is much better than trying to take care of these patients in the emergency room. And it is a major cause of school and work absence from school. So asthma causes a morbidity, which we are dealing with daily. However, it does cause a mortality. And one of the major reasons why asthma causes a mortality is that we fail to recognize the severity of asthma. The kids, they come to the ER coughing, take a ventilator nebulizer, go back home, come again, take the nebulizer at home, until they come in a state which is irreversible, and they might go to the ICU. So if we fail to recognize patients with asthma who are in need for admission and who are in need for extra care in the ER, then we'll end up with asthma mortality. Now, it is a heterogeneous disease. Usually, the heterogeneous disease that usually characterized by chronic airway inflammations, the symptoms and the signs of asthma, I'm sure you are aware of. It ends up in wheezing, shortness of breath, chest tightness, and cough. And if we look at the symptoms are caused by increased mucus production, and behind this is a huge list of immune modulators, resulting in increased mucus secretions, leading to chronic walled airway thickening, and symptoms can be triggered or worsened by upper respiratory tract infections, exposure to allergens, exposure to tobacco, exercise, and stress. This is a very simple diagram showing you that exposure to allergens will induce the eosinophilic flood of eosinophils, which causes airway hyperresponsiveness, resulting in symptoms cough, wheeze, and dyspnea. Now, how can we diagnose asthma? Asthma, unfortunately, is one of the diseases that you cannot collect a blood test, send it to the lab, and get the answer. Asthma is diagnosed by constellation of signs and symptoms supported by some tests that we do. So if you have the history of shortness of breath, cough, you have to trigger in the history whether these are related to seasonal changes, viral infection, upper respiratory tract, or exposure to smoke. Sometimes you get patients who are walking in the avenues before the ministry starts to forbid people from smoking in public places, and they say, whenever somebody passes smoking cigarette, I feel tight, without them wheezing, and this is the issue. And then if you take the history, look at the clinical signs, examine the patient, perform a spirometry or peak expiratory flow, put things together, then you can reach a diagnosis of asthma. In pediatrics, we can also measure the airway hyperresponsiveness. And this is sometimes it's not feasible if the kid is under 5 or 6 years of age, as you cannot perform a formal lung function test. What we do in these cases is that we give a test dose of beta-2 agonist, check the reversibility clinically of the airways, and this will give you a hint that this is bronchial asthma. Measurement also of the allergic status, which cannot be officially done in kids under 4 years of age or those on long-term steroids or an antihistamines. We can do skin breath testing, which is performed by the allergist, immunologist, and this will help us to see if they have an external allergens. Extra measures are required to diagnose asthma, of course, in the elderly and in the kids under 5 years of age. Now, can we prevent asthma? You will have a patient in the clinic, the parents come very concerned, we don't want to have the inhalers, we don't want to be treated as asthmatics for life because it's a chronic disease, so we want a cure. And in these cases, it depends. Usually this is very difficult, but if you have a patient with a specific allergen whom you can avoid, like if you have a father who's a very heavy smoker and he comes to the clinic, he swears he stopped the smoking and you can smell it 10 meters away. And then he comes, he hugs his kids, kisses them, and then their asthma is never under control, although the mother swears that she does everything you told her. So removing external allergens and external factor, living in a place with heavy smoking is not helpful at all for asthmatics. So if you can separate the patient from the predisposing factor, this will be great. However, in cases of asthma, this is very difficult. So we can avoid exposure to tobacco as much as we can, but we cannot remove the patient from exposure to allergens unless it is a very single allergen that is detected by skin breath testing. Sometimes you have kids going to the horse riding, and whenever they go there, they will have an acute asthma attack, or the introduction of a rabbit or a parrot to their environment is usually associated with increase in their symptoms. So you can trigger a precipitating factor, and this can help by removing this factor from their environment. The current recommendations are to avoid exposure to tobacco, encourage vaginal delivery, and advise breastfeeding, and this is a general advice. Can asthma be treated? Yes, asthma can be effectively treated, and this is our job as pediatricians. And when asthma is well controlled, the patient should lead a normal life, be physically fit and active, go to school, no more school absence, have near normal lung function, and avoid, the most important, avoid serious asthma exacerbations, visits to the ER, and admission to the hospital. Now, who are the patients who are at increased risk of asthma-related deaths? As I mentioned earlier, asthma-related deaths is a major issue in treating asthma nowadays. So who are these patients? Patients are at increased risk of asthma-related death should be identified very early with the following points. Any history of near-fatal asthma requiring intubation and ventilation. It's not uncommon in our practice that the first attack of asthma, the patient comes to the ER in severe respiratory distress and get intubated. And going back to the history, you will not find any clue that this patient has asthma before. Negative family history, nothing at all. His first attack of asthma, he comes, he gets admitted to the ICU. There is no, the patients who are visiting the emergency department very frequently, those who are hospitalized in the last 12 months, patients who are not using their regular reliever medications or preventer medications, or patients with a very poor compliance and adherence to their treatment. Those who are currently have been using oral corticosteroids, which is our strongest weapon that we use in asthma. So if they have been using short courses of oral steroids, this means that they are at high risk of coming to the ER in a very severe asthma and gets admitted to the ICU. Who are the patients, again, at asthma-related deaths? Overuse of short-acting beta-2 agonists, especially of more than 1 canister per month. And this is very important because they keep going to the polyclinic, get a Ventolin nebulizer. Nobody tells them that you need to be seen in the outpatient. Nobody bothers to tell them that you need a preventer medication. And nobody sits down and explains how serious asthma can be. So he keeps going upper respiratory to the polyclinic, and this is our daily practice. Take 720 nebulizer every now and then if they reach a serious dose, then they will be unresponsive. And they are not unresponsive because